that they wish to declare?
No.
No? Okay. And then item 3, public participation. I believe we don't have any public participation.
No, Chair.
Okay, thank you. Item 4, confirmation of the minutes of the previous meeting. Can I have a proposer for those minutes, please? Richard, yep. And a seconder? Anthony, yep. Thank you. All those in favour? That's carried, thank you. Okay, that brings us on then.
After the meeting.
Yeah.
Yeah.
Yeah. Okay, that brings us on then to item 5, which is the Care Quality Commission report, found on pages 1 to 6 of the main agenda pack. If I can first move to the Cabinet member to introduce the report. So, Councillor Alcott.
Good morning, Chair. Thank you, and good morning, Scrutiny. Yeah, obviously we've had the CQC report now, and I'm really pleased with the result. I did previously, as Chair of Scrutiny, I did have the opportunity to speak to CQC in that position, and also thank you to Councillor Hardman at the time who spoke to them as the shadow spokesperson. But yeah, obviously we have a good overall rating, you know, 70% score, which I'm absolutely delighted with, and in 4 out of 5 areas we've scored good 75%. We just have a couple of areas that requires improvement, but with all things considered and our current cost base, I'm absolutely delighted with that, and I'd just like to hand over to Mark. Thank you.
Thank you.
Thank you, Councillor Alcott, and thank you, Chair. I'll be brief, really, in relation to introducing the report. As Councillor Alcott has already said, that our overall rating for Worcestershire Adult Social Care Service, and in fact, obviously, the Council's ability to deliver that service has been rated as good. However, in terms of, I'll just step back and say I'm absolutely delighted that we got that outcome, and I think it was well deserved in relation to our workforce in adult social care and the dedication and commitment that's given to the work that they do, and that was actually recognised quite strongly in the CQC full report. Out of the 9 themes that we assessed against, we had 2 areas that requires improvement. So we won't be resting on our laurels in terms of that. As Councillor Alcott's already said, we did, I think it was at least 4 of the other themes, we got a 75% rating. Our overall rating percentage-wise was 70, which I think gives us a strong good. It wasn't just over the line from that point of view. But as you'll see from the report as well, as I say, we won't rest on our laurels. There is an improvement plan being worked up, developed and in place arguably now. And obviously we'll be working on that throughout the next 12 months to try and get those 2 requires improvements in a better position for any future inspection. But importantly as well, make sure that we maintain our good performance in the other areas that we obtained. So I'll say no more than that. We've got colleagues here to take any questions, and I'll hand back now in terms of any questions that we might have.
Thank you very much, both. Yes, I'll open the floor then for discussion. So I've got Tor first.
Thank you, Chair. And thank you for sending this summary of the report. It's really good to see a good report. I don't know what other word to use. And there are so many positive things in this report, but obviously I wouldn't be doing my job in scrutiny unless I spoke about the negative things. So I'll start with an apology for only talking about the negative things, but I'd like to save some time. So there's a few things that we need to improve on in the report. One of them is there's gaps in protected characteristics. I'd like to know a little bit more about where the gaps are in terms of protected characteristics, specifically who is most at risk, who is anyone at risk of poorer outcomes, because we're not, keeping this data on these people. Do you want me to list off all the things I've got, or do them one at a time? I'll do all the things. The next thing is about rural access, and I want to know a bit more about how much this is an issue with transport compared to staff availability. And then the last one is about specific plans to improve carer registration. Obviously, unpaid carers are really important. We need to make sure that we have a good log of who exactly is out there providing care. I just want to know a little bit more about what plans we have to get those people on our books and make sure we know about them. And then I guess the overarching thing for this is it's about a bit more about like timeline, what timeline we can expect for this improvement plan. When will we get a check-in at any point on this improvement plan before the next CQC assessment? I don't know much about CQC assessments. I know about Ofsted. I know how often they come. I don't know how often CQC come and assess you. So if you could give me a bit of an insight on that, would be great.
Can I just first of all pick up on your last point there? In terms of the framework for the assessments going forwards, then any local authority that receives a good rating would normally not expect to have another full comprehensive assessment within 3 or 4 years in that sense. So that's the sort of regime that is now in place. However, we are required to do an annual self-assessment. And along the way, we could have a situation where CQC decide to do a focused assessment on a specific area within a local authority. Now, that annual assessment, if you like, wouldn't necessarily change our rating, and a focused assessment wouldn't necessarily change our rating. It's only after a comprehensive assessment that you may have a change in ratings from that point of view. However, again, because of the way that CQC have staged the assessments, they've got a number of authorities that are good, and they can't wait for 3 to 4 years on all of those authorities. So we're already seeing some early signs of actually CQC coming back, even to good authorities, at an earlier point in time.
Thank you. I don't know if there's anything else you want to add on that, Tor, or you're happy? Yep. Okay, Andrew? Sorry.
Yeah,
I
sorry.
jumped in
So
too soon.
if I can just hand over
Sorry.
to Kelly, really, maybe to answer the first question that you posed in terms of protected characteristics.
Hello, my name's Kelly Palmer. I'm the Principal Social Worker for Adults. So what the CQC report identified is that we didn't have golden threads going throughout for EDI, so that was where the main point came from. In terms of protected characteristics, we do look at it, so commissioning do their market statements, and they do look at what's in the market and what our demographics are, looking at the JSNA and stuff. In terms of social care, what was happening is that on our record system, we don't have the percentage that we would like to see protected characteristics recorded. So what we're doing about that at the moment is we've just revised our recording guidance. We've just revisited our LAS, which is our case tracking system, and how we record on there. And we're currently looking at the reports available to see how we can look to identify where the gaps are and how we can then work with the staff to increase the recording of protected characteristics.
Has the lack of recording of protected characteristics, has that led to any worse outcomes, or is it just that we're just missing some data?
From what we've seen so far, and from what CQC report to us, it's missing data. It's not that people received worse outcomes. So where somebody, for instance, has protected characteristics, it is seen in their assessments and it is seen in their support plans. It's just the missing data part.
Just on then the second point, I think it was around transport really, and the access and rural inequality. I think this particular issue really points, I think, back to the council's approach in relation to transport, not necessarily adult social care transport issues in that sense. I know there's been a lot of work that's taken place in terms of transport on demand, etc. But I think in terms of that particular issue, then I think it requires a council response as opposed to just adult social care. And we'll be working with colleagues to see what we can do about that in terms of improving, access to transport, not just for people who use adult social care, but more generally in the rural areas, really.
So in terms of carers, we work quite closely with what they're called carers and communities now. They've changed their name recently from Worcestershire Association of Carers. So they hold a carers register. So what we're aware of is that there are a lot of carers out there that don't necessarily come to social care. So we're currently working with the carers and communities to look at how we can outreach to the carers that we aren't aware of. Those that we are aware of in adult social care, we have updated our needs assessments. In the needs assessments now, it does ask that question if there's a carer or if there's somebody that provides care that doesn't want to be recorded as a carer, because that also sometimes happens. And from that, that's how we're encouraging social workers to get more carers put onto the system.
Can I just add to that as well, please, in that certainly as part of our push to continuously try and identify carers, is actually we do have notifications in a lot of public spaces such as libraries and GP surgeries and so on to prompt people also to try and get in touch if they are actually a carer. I think one of the issues is that a lot of people don't see themselves as carers, even though that they are. But we do actually make sure that we do have information, as I say, in a huge number of public places as well, to try and get that message across.
Okay, no, that's brilliant. Thank you. Andrew?
Thank you, Chair. Thank you for the report, and thank you for the really good work that's led to this good rating. I was just a little bit puzzled because when I read the report to this meeting, I had some questions, and so then I turned to the CQC document and I found some of the details that I was looking for. So, for example, about deprivation of liberty, that the that the numbers about the backlog, etc., were how many applications, all those sort of details were not apparent from our report pack today. But thank you for including the link. But it would have been useful to have had these within the scrutiny report. And I don't make it. So I believe the report is factually accurate, but there are some nuances and balances that aren't apparent from the report in front of us. Yes, in some ways it understates the strength of prevention and co-production and partnership working, amidst some of the CQC concerns about quality assurance and scrutiny, and softens some findings. So there's some. It's not biased. It's just there's some positives within CQC that aren't apparent within our report, and there are some criticisms within CQC that aren't apparent within the report. And so I would just welcome. Obviously mistakes can happen, or officers are under stress, etc. But it would just be helpful to have things more immediately apparent within the scrutiny report, if that's a fair point to make, please.
Thank you, Mark. Yeah.
Yeah, thank you, Chair. Noted. I think obviously what we try and do for Scrutiny Committee is give some précis of what was a fairly extensive report really in terms of that, hence the reason we provided the link as well. If people wanted to go into more detail, then that was available to do that. So we've tried to strike a balance between just having a front sheet here really of a report around the overall CQC report. And I suppose that's the rationale really for not just repeating everything that's in the link.
Thank you. Yes, I do appreciate looking for info within the CQC report is a bit like looking for a needle in a haystack. So just in terms of person hours avoided, one person doing a real distilled summary could save several people a few hours. But I appreciate the pressure that officers are under.
Thank you. Okay. Any other members wishing to raise any questions? Yeah, Richard.
Thank you. Well, first of all, well done. I had no doubt that CQC would give an overall, very positive report. From my evidence, when I was cabinet member, we have a great workforce in adults and do a terrific job day in, day out, in often very difficult circumstances as well. So I believe we are very, very fortunate. But this is about continuous improvement and how we can take things further. So I've got a few points to make. First one's about the task team, Targeted Adult Support Team, who, again, do a superb job. And I know it's partly funded by Public Health. How can we develop that further, even? We know we have a waiting list. We know we have demand that needs to be taken up by the task team. So how can we even engage that preventative nature even more than we do and extend it? I think that is a critical area, perhaps working more with social prescribers as well and the community. Secondly, it's on leadership and governance, which was, I know we are very fortunate. And Keith Brown, our chair of Worcestershire Safeguarding Adults Board, and we should actually thank him for his input and support as well in what he does to help us with CQC and our activities. I asked him once, what did he think of our adult social care, and he did rate it good himself, and he has a role within many different local authorities on adult social care. And I said, what is it about us that's good then? And he said, the leadership team. We are so fortunate with our leadership team. So thank you to everyone sat on our left for all your work and everything that you do in carrying out, which we know is in very difficult circumstances, not just with the work and the situations that your teams are involved in, but with the budget constraints and the pressures that we're on daily. Thirdly, access to rural inequality, which Tor just mentioned with transport. I'm doing a self-plug here as Wychavon's leader. We are now going to embrace the on-demand, which was initiated under our administration, and we're going to just charge passengers £1. And the reason behind that is that we believe transport within the community is so really important, perhaps particularly rural communities, with their mental health and their opportunities to get out and about, and youngsters to access provisions from a rural community as well. So hopefully that will have some impact and perhaps encourage others to follow suit in terms of the rural communities that we have. Four, where I do think we can improve and do even more is perhaps with our partnerships and working with our voluntary sector and the third sector. Having had my own experience, many know that I had a heart attack last October, and then my drive, as often I do, to try and bring people together to find solutions. I can see that we don't always do that. We don't always bring the people that need to be brought together, and that's from the NHS, from the GP practices, from the voluntary sector, the community sector, people that can add value. And I think we need to be doing a lot more of that to try and bring solutions and to help our budget as well in what we do. So there's some observations there, and not just questions, but I put it in to help the discussion.
No, thank you very much, Richard. Yeah, so Mark, do you want to respond to those? Yeah.
Thank you, Chair. Thank you, Councillor Morris, and thank you for your insights, really, and particularly in relation to your acknowledgement of the workforce. And I hope we lead that workforce, as you've just described, in a good way, and we've got a strong leadership team in relation to adult social care. I wouldn't argue with any of the points that you've made. I think in terms of specifically around TAST, as we'll all know, we are committed to a wider council transformation programme at the moment, and I know one of the areas we'll be looking at the council's overall front door approach to how we engage with members of the public. So I'm sure that will come into the conversation in terms of how that service is currently provided and whether we can make any improvements to that response and the council's response to people in the first instance. In terms of I think it was more a statement, wasn't it, in terms of access and rural inequality, but that's great to hear that those things are already taking place in Wychavon from that point of view. And again, as I say, that's where it can't just fall to adult social care to consider those things. It is a wider issue that was picked up in the report. And in relation to partnerships, I guess the one thing that springs to mind for me in terms of how we bring health and care services much closer together in the future, and our voluntary and independent sector as well, then I think that is the plan in relation to the neighbourhood health and care plans that are embedded in the NHS fundamentally, but will impact on adult social care and how we join things up better into the future. So I see that as the opportunity really to strengthen those partnerships in our neighbourhoods and that neighbourhood model of delivery for health and care into the future.
Thank you. Yep. Kerry, yep.
Can I just quickly add in relation to TAST? So Mark referred to the reorganisation of the front door of the council. TAST isn't directly in scope for that first phase. So I just want to make that clear. We might have staff listening. But what we are doing with TAST, which for those that don't know is the Targeted Adult Support Team, they're a very short-term team with who set outcomes, goals with people over a short period of time to promote their independence. It's an absolutely fantastic service. One of the things we're doing at the moment, because clearly with the challenges of the finances, prevention is very difficult to put pound signs next to, because if you're not spending it, you're not spending it. But actually it's that cost avoidance. So we've just launched something called a social engine value tool, using software to try and translate the social, environmental and community benefits to individuals against a pound sign, so that when we're then looking at project work, which we've got a number of different strands of work underway, we can start to understand and evidence the benefits to people, but also the benefits in terms of demonstrating that impact of use of funding using public health funds. It's partially council funded, and being clear then with stakeholders and those that make decisions why we should invest more in those type of services. So I just wanted to let you know we've got that piece of work underway. It's fairly new, but it's telling us the results that we knew it would tell us in the early phases of that.
Thank you very much. Okay, so moving on then. So I've got Sue next.
Thank you, Chair. Thank you, Mark, and the team for a really good report. My question is on page 3, the key gaps, the poor recording and protected characteristics. Given these figures, does that mean carers are still being failed in care, support, respite, emergency planning, and of course registration? What urgent action is being taken now to stop these gaps, putting carers at risk, especially carers with complex needs? And also concerned that emergency plans are inconsistent when carers rely on them in crisis. What has been action to make this consistent, and what help is going to be offered to unpaid carers in the future? Thank you.
Thank you. Mark, yep.
Thank you, Councillor Leacock. I think you heard before in relation to informal carers or unpaid carers, then, you know, sometimes we're not necessarily aware of those unpaid carers because people don't necessarily see themselves in that role, in that sense, and don't identify as a carer. Often if you're looking after a relative or a partner, then you see that as part and parcel, I suppose, of that relationship that you already have. So it's often very difficult for us to reach those people. But as Rebecca alluded to as well, it's about trying to raise an awareness to people and communicate that there is help and support available to people, and just to come forward if that's what they need. What we also have, obviously within the report, it talks about making sure that assessment staff, social workers broadly speaking, are fully versed with identifying informal carers through their assessments of the individual themselves in that sense. And we do have a good relationship with our carers service in the independent sector and a contract with them to deliver that care and support, and they will do their own work to try and identify carers where it's possible to do so. But when we are aware that there is an informal carer who needs support, they will get that support through an assessment.
Yep, Kerry, yep.
I think as well it's important to note, and it's not undermining what we read within the CQC report, we totally accept that. There will be, as part of the CQC inspection, things that are within the report that may only have come up once in a conversation rather than them being a large-scale issue, for example, with contingency planning and or respite provision. And that's the importance of seeking feedback, but it is quite limited. And certainly we approach CQC as part of our review of the report to get any particular details that they were allowed to share with us in order for us to take any of those conversations forward. I think respite provision quite often can come up, and it's not that people won't receive respite as and when they need it as carers, because they absolutely do. And in emergencies, we've got social work teams on duty every single day in order to respond to that, particularly if a main carer goes into hospital, for example. What we have done is improve recording of advanced planning, what would happen if my main carer went into hospital, what's the person's views and wishes, and the carer's views and wishes. So we'd already just implemented those changes, but not long before CQC came on site. So they may have seen some records where that wasn't particularly as strong as it would be now, because we've got those prompts within the new paperwork. But also we do sometimes hear that the advanced booking of respite within care homes is quite challenging, because we haven't got those block, I'm sure Rebecca will come in, but where we haven't got contracts that reserve beds effectively 100% of the time that are paid for, of course we're reliant on what those vacancies look like, and many care homes won't want to advance book too far ahead for those vacancies. But within the general market availability, it's not an experience that we would see commonly where we can't meet that need as and when it's required, but some people would prefer that to be understand where they're going much sooner, i.e. when they may book a holiday 6 months before, they would like the provision confirmed, and that's something that we would find quite challenging within the market to do.
So, yes, to add to that, the respite care can take many forms. It's not always in a residential setting. It could be through some domiciliary care support. It could be through a range of different routes. And our contracts do facilitate that care to be in place as and when. As Kerry has said, in terms of residential care, we do not block contract a number of beds around the county to accommodate that. And we don't do so because, one, our market has sufficient vacancies within it that we can find respite care, but we do not book it. If we booked it 6 months in advance, we would have to pay for that bed to remain empty for the 6 months running up to that leave being taken. And so our contracts do permit, so if we take the residential settings, there is a premium that is paid for the short-term care, but we do not block book a series of contracts, because actually we would, as I say, have to fund those empty beds all of the time that they were empty, whether, irrespective of whether or not they were used. But we do have sufficient capacity across the markets to actually accommodate the care as and when it is required, and certainly we don't have difficulties in doing so, even when it is an emergency situation.
Thank you all. Is there anything else you want to add, Natsu, or happy? Okay, I've got Michelle next.
Thank you, and echoing other sentiments on providing this summary of the report, and it is reassuring that we've got a good rating. Very much picking up on that last point, and actually my question has already been partially answered, but it is stated as an area for improvement that the respite care availability is one of those areas, so I might just query the latest answer given to Sue's previous question. But also, and I note it says that the team has begun developing a comprehensive improvement plan with targeted actions to address the areas identified as needing improvement. So my question, excuse me, will be when will this plan be available to this committee, please?
So, as Mark said earlier, because this goes outside of the directorate, we are having to work with other directorates and other colleagues to formulate the plan. The draft is almost complete, so I would hope to see a formulated plan given to Mark and Kerry sometime in September.
Okay, thank you very much. Anything else to add on that, Michelle, or no? Okay, I've got Anthony next.
Thank you, Chair. Good morning. This is my first time on this committee, so hello to those people I haven't spoken to yet. The question I've got really isn't as much for education. as anything else, and it goes to page 2, the paragraph 9, the quality statement scores. I'd just like a little bit of sort of explanation as to how we seem to be assessed as being good at assessing needs, but care provision requires improvement. Prevention, healthier lives, self-guarding are all positives, but we are poor on integration, equality and experience and outcome. So, I mean, are these problem areas that need to be addressed, or is it just really continuity as you go through the system that is just creating this?
Thank you, Councillor Upton. I think we've already suppose in terms of the inequalities and some of the questions earlier around protected characteristics, and I think we recognise that is an area, arguably not just, if I can be this bold, for adult social care to improve on, but perhaps as a council in that sense, and make sure that we've got a consistent approach across services, not just adult social care. So we do recognise what's been put in there in terms of that requires improvement and the need to take that forward. What I would say on the other area where it requires improvements, it was specifically in the more detailed report around transitions for people, and that wasn't just transitions as we sometimes think of it from children's to adulthood or adult services, but transitions in people's care. So it might be around a person's discharge from hospital back to the community, and there was some elements around how well we communicate with people then about what they can expect from that transition period, if you like, from services in that sense. I think I would just draw, and it's not to be over defensive in that sense, but as Kerry said earlier as well, sometimes you can get one comment being made by somebody who perhaps has a louder voice in the CQC assessment process, and if that's picked up on, it's often used as a blanket example of how we provide services, when in fact it might be a very isolated incident that's been picked up on, but then a judgment made overall about the area of service provision.
Okay, thank you.
Okay, thank you. Dave.
I think my question's been answered already after listening. It's one of the benefits of sitting here, really. Thank you very much.
No, thank you. Andrew?
Thank you, Chair. Yes, I have a question and a comment. So keen to hear about the service, the improvement plan. I note that the draft is almost complete and is hoping to come to this committee in September. I'm just wondering which of the actions within the improvement plan one could indicate could or should be completed within 6 months, and which will require longer term system change. And also keen for your inputs and thoughts about what the key, let's say 3 key measures would be that members, all of us, should basically monitor to see how we are progressing with the improvement plan. Thank you.
So in terms of the priorities in the improvement plan, what we're going to focus on first are the areas that we got requires improvement on in the report. So things such as EDI and what was the other one? Integration. So those are the ones that we'll be focusing on first. So until the draft is complete, we haven't rag rated it yet, so I can't really give any comment on the priorities, or which I would like the committee to consider as the top ones at the moment. But once we've rag rated it, I'll be in conversations with Mark and we can provide some update.
Okay, yeah. Andrew, yeah.
Yeah, I was just wondering if there are any quick wins that we'll be able to get within this.
Yeah, I think it's really important to note that we're not sat back while we're waiting to complete an improvement plan. So right at the beginning of inspection, when we had the opportunity to do the leadership presentation, service managers presented to CQC all of our service development work that we're focusing on now and through the inspection period and beyond. So work is underway in relation to all of those areas. So, for example, an area in Francesca's field in 2 areas there. We've got continuing healthcare and learning disabilities. One of the key pieces of work that we want to improve in learning disabilities is our relationships with learning disability health services and how we can start to form a stronger partnership working relationship so that we do get better outcomes for people and families with learning disabilities. So that will already be on Francesca's service improvement plan, and we would already have identified that as an area that we want to improve on to CQC ourselves. So what we're doing in the overall improvement plan for CQC is amalgamating all of those plans into one document, which we can then rag rate and prioritise because resources are really tight to do some of this work, particularly with LGR pending and also needing to have some focus on that area. So that's what we will have in a sort of draft format by September. But it's really important to say that it's not that we're not doing something. So to give you an example of some work that we're trialling at the moment around continuity of care. So some of the feedback was that, for example, if someone's moving from residential care to nursing care, but they've had a hospital admission in the middle of that, how we then communicate to the existing residential home, the hospital discharge team, the new nursing home, and how long some of that can take. And there's so many stakeholders to communicate with within that process, the person themselves, the family, etc., etc. So we've started 2 pilots within the hospital over the last couple of weeks so that we can start to speed up the discharge process, reduce those delays, but also provide then some clear communications in terms of what that pathway looks like. So that's already a piece of work that we're doing in partnership with the Acute and Health and Care Trust and individuals to start to improve continuity of care in that one specific area, because that was something that we absolutely noted within the report. So just some assurance around that any of those quick wins, we're absolutely doing the work on those now, but the report will incorporate all of our service development work, and like Kelly said, anything relating to the 2 requires improvements will automatically then have that as a priority rag rating.
Okay, thank you. I'll be inclined for a bit of steer from the panel with regards to this, but I wonder if it's worth at a future meeting that we bring the improvement plan forward as something on one of those agendas so we can look at that in more detail. Yeah, got a lot of nods, so yeah, if we can take that one away then, and we'll see what we can do. So I've got Sue next to speak.
Thank you, Chair. My question is, again, on the poor recording. Is it a concern that given up to 70% of protected characteristic data is still currently missing? Is AI being implemented to record data? If so, will this increase the cost to adult social care budget?
Certainly the plans that we've got in place to improve that wouldn't have a cost attached to them. It's difficult in terms of data recording. We have multiple reports that flag missing data, and we have, if we're honest, had reductions in administration support, for example, in trying to support the running of those reports and constant oversight of where we've got gaps and making sure we can fill them in. And one of the things that would be an obvious question is, why don't we make it mandatory? We can't make it mandatory because every day we're managing really critical emergency situations. It might come through the front door, it might come through the safeguarding portal, it will come from partners, police, WAMAS. There will be lots of missing information and we need to act. We need to be able to get information from A to B to C. And if you make something mandatory, then you stop the ability to move it on without being able to get those questions answered. And you end up with lots of information that actually says unrecorded or not known. And that isn't the data that we want to have in our system, because that doesn't give us any intelligence at all. So, the work we are doing is making sure that we can get as much of that upfront as possible. that we're working with partners who refer in through portals and the adult front door to provide as much of that information as possible. But then where we have got gaps, running those reports and making sure that we go back at the appropriate time to ask some of those questions. And it isn't always the appropriate time when people are in a crisis to be having some of those conversations. So it's just important that we've got some resource able to improve that data. But that 70% will be a rolling, it will be different people, we'll add data and complete records and new ones will be coming through, and so we're never going to get to 100% around that data, but we do absolutely want to improve the current position, there's no doubt about that.
Thank you. Any further questions or comments from the panel? No, I'm conscious we've got members of the councillors which aren't on the panel. Is there anything you want to add on this item at all? Joe, yeah.
Good morning. I've got a couple of questions, but firstly I want to say thank you to the officers because I worked quite closely with them, well, very closely last year. But I also want to say thank you to the former cabinet member who I've never seen a councillor work so hard in all of my 5-6 years here. She put in everything to get this CQC assessment over the line. So I just want to say thank you to Councillor Eacock on that one. So what I want to ask the question about is the equality data. Everybody's been saying how we're going to improve it, but nobody has said why or asked why is it missing. You know, I want to know exactly why is it missing, because then we can learn how to improve it. And I do think AI is going to help. Sue's question was very important, but I don't think it was answered fully, and I think we could go back to that. But also, receiving an overall good CQC judgment is a significant achievement for Worcestershire. Can the Cabinet member confirm whether they intend to maintain the existing improvement programme which led to this outcome, which was prior to her being Cabinet member? Or are there any significant changes planned? And this subtly reminds everyone that much of this inspection period covered the previous administration and not the current one. Thank you.
Thank you. Yeah, Mel first, yeah.
Yeah, Chair, thank you. Yeah, obviously we now have the CQC report, and the key thing now is to look at the action and improvement plan with that and look at where it requires improvement, but at the same time ensuring that we maintain the status of good within that. And I think also we need to have, as a council, a focus on, obviously we should know on Thursday the outcome from the Minister on whether we're going to be north or south, and I think we need to pause and wait and see, because we should have that answer, and that will make a significant difference as to the work that we need to do. So I feel that we're in a bit of a holding pattern, but once we're there, I think then we can finalise and strategy and where we're going from there. Thank you.
Sorry, is there anything else anybody wanted to add on that one? Or no? Okay. Happy with that, Joe, or any further points?
I don't think it was fully answered, but I'll accept what's been said. Thank you.
Okay, thank you. Nick?
Thank you, Mr. Chairman. Firstly, I'd like to congratulate everyone involved. I think achieving an overall good rating is something the Council should be proud of and reflects the dedication of our workforce, and is a great achievement for Mark and his team. But I'd also like to take this moment to actually praise Councillor Eacock for her work here as previous CMR. Her time and dedication here has really proved dividend in the result that we've achieved. Also, this report was concluded during her tenure as previous CMR. But however, scrutiny doesn't end with a positive inspection. Our job is to understand where improvement is needed and how it will be delivered and how success will be measured. So, as Mark has kindly highlighted, the report identifies a number of improvement actions. So the main thing really for me is, on your draft plan, how are you going to pressure test it? What do you envisage the timeline to be to deliver the improvements? And will these be achieved ahead of the next inspection? Additionally, following on from Councillor Pingree's and Eacock's comments, the report is quite critical on quality. Has that affected commissioning decisions? And additionally, what action will the new CMR take to improve these, to ensure these improvements are delivered? And what does success look like for her? Thank you.
Thank you. There's quite a few questions there. So if I take Mel first, if that's right.
Chair, thank you. Just give me a second. Just need to switch screens. or maybe more than a second. Okay, yeah, with regard to adult social care, and I would like hopefully I'll get the opportunity to talk more on this post full council on Thursday, but obviously we have a motion of no confidence in the leader, and the result of that may change who is on cabinet, so I won't talk in detail today, but I would like to say, yeah, a vision for adult social care for me in Worcestershire from now until I would say vesting day, the 1st of April 28. Social care is about people, it's about enabling every resident to live with dignity, independence and purpose, whatever their age, disability or circumstance. And my vision now is to ensure that between now and vesting day, we create an adult social care system that is, it's great now, but let's make it even stronger, more resilient and better prepared for future than the one we inherited. The coming years present significant challenges and demand for care continues to grow. Our population is ageing, recruitment remains difficult and public finances are under sustained pressure. And particularly, I think, following on from last year, they are now under even more pressure. And I'm not going to be political. At the same time, obviously, Worcestershire will undergo one of the biggest changes in local government for generation as we transition towards unitary government. But rather than seeing that as disruption, we should see it as an opportunity to redesign services. And I do have a vision and I have 5 guiding principles, but hopefully if I'm still Cabinet member on Thursday, I will talk about that in detail and I hope you will appreciate time on that. Thank you.
Thank you, Chair. Councillor Price just reminded as well, really, not alongside our focus in Worcestershire and what we want to do to make improvements to adult social care, then we've also got in the background Dame Louise Casey review taking place. There is meant to be an interim report out this year in relation to some initial recommendations that she may well have. The full report is still looking towards 2028, but you know we will be looking towards that overall national picture of adult social care in terms of any reform that brings change along with that particular review.
Thank you. Anything you want to add on that, Nick? Or
No further questions, Chairman. Thank you.
Okay, and Joe.
Yeah, sorry. I don't think I got the answer to my question regarding why. Why is the data missing?
Thank you, Councillor Monks. I think it refer really to Kerry's answer before, and one of the issues is around we can't, you know, it's not a mandatory field on our recording system from that point of view. The reason, as Kerry has said, really, it's not mandatory is that we wouldn't want that to necessarily be a block to service provision as we, you know, often have to meet people's needs in crisis. But we are committed to making sure that an opportunity in time for those individuals that we work with, that there is greater emphasis of going back and making sure we've captured that data, not just at the start of the process, but at any point in time then after we've provided some care and support, really.
So just to lead on from what Mark was saying, as Kerry alluded to, we made some changes to our assessment documents not long before CQC arrived. One of those changes was to incorporate all of the demographic information at the start of the assessment. So if it's changed at the start of the assessment, it will then change automatically into the system. What I don't know at this time is how well that's embedded, so that is something that we need to look at as part of our improvement plan.
Yep, okay, brilliant, thank you. Any other members of the panel wishing to comment on this item? No? Okay, well, we'll move on then. So if we move on to the next item, which is the Adult Neurodiversity Team. So I've got with us, so I believe, Kerry, you're introducing the report? Or Mel, sorry, I'm not sure which one of the two of you which wants to go first.
Hi, yes, I'm just going to introduce Francesca Darby, who's our Head of Service for lots of things, continuing healthcare, learning disabilities, and the Adult Neurodiversity Team. So Francesca today will focus on the work of that team. So I'll hand over to Francesca.
Thank you, Kerry. I won't introduce myself because Kerry's kindly done that for me today. So members will have seen the report that has been shared, and I'll just highlight some key points because you already will have seen the detail. So the report provides an update on the development of the adult neurodiversity team since it was established in April 2023 following the review of the previous vulnerable adults team. The service was developed to ensure that we, as a local authority, are meeting our Care Act duties for autistic adults, whilst also providing a more preventative, specialist and autism-informed approach. In terms of demand and need, one of the key messages is that demand for the service is both increasing and becoming more complex. So when we had our CQC self-assessment work, one of the issues that we'd identified for this particular area was around capacity, and that's been a theme throughout. So between April and August 2025, active caseloads increased by around 13%, with demand remaining higher than previous levels throughout the year. The team supports some of the most complex individuals in adult social care, including people experiencing housing instability, mental health overlap, crisis presentations and high-cost placements. In terms of the work of the team, the focus, as with adult social care, is on prevention, early intervention and reducing escalation into crisis services wherever possible. We have introduced a model which combines qualified social work oversight with specialist support workers to provide proportionate support at an early stage. In terms of examples of impact, so I've put some case studies in the report, but the report does include some examples where early intervention has prevented long-term dependency on services and supported people to move towards greater independence. In some cases, individuals who were initially expected to require lifelong support have actually been able to move towards more independent living following strength-based assessments and targeted intervention, and that's exactly what the heart of our autism strategy is about. The team also supports people with very complex needs, so there is a range from people that are fairly independent to people that are quite complex, where the focus is not necessarily on reducing the support, but actually preventing crisis and avoiding hospital admission and maintaining stability. We obviously don't do this work in isolation. We're very reliant on system working and system leadership. A key strength of the team is the ability to work across the traditional organisational boundaries, and the team works very closely with health colleagues, housing partners, children's services and commissioning teams to support smoother transitions and improve housing outcomes and reduce crisis-driven interventions. The team also has a dedicated housing officer who works across the system, recognising the significant impact housing has on independent and well-being for autistic adults. In terms of challenges and future development, whilst there has been significant progress, as with our CQC improvement stuff, there's more work to do. We want to strengthen how we measure and evidence outcomes. We also want to increase engagement and co-production with people. So we've got a dedicated autism partnership board, and we really want to increase our co-production with them going forward because we want to increase the links that people have with the service. We will also continue to monitor demand and ensure the service remains sustainable and ensure that we develop our understanding of the financial impact and benefits of working in a preventative fashion. So overall, the report demonstrates that the adult neurodiversity team is providing a more specialist, preventative and person-centred response for autistic adults. It is helping people to remain independent for longer, reducing the risk of crisis and ensuring that statutory social work resources are focused on where they're most needed, while supporting the council to meet its Care Act and autism strategy responsibilities. I'm happy to take any questions. Thanks.
Thank you very much. Okay, I'll move to the floor. We've got Dave first.
Thanks, Chair. Thank you very much for the report. I think one of the things that's come out at this point today to me is trigger points and timings of review. And one of those at item 14, where you've identified a service review and it was undertaken. I suppose my point would be, you mentioned then you were monitoring the issues. So is there a plan of fixed monitoring? Is there a plan of timescale, or are there triggered events that cause that review to happen, if that makes sense?
Thank you. I think in terms of continuous improvement of that service, that feeds into our CQC improvement plan. So there wasn't necessarily a trigger, excuse me, that led to the review of the service, but it's around capacity. And that's something that when we did our self-assessment work looking at the service specifically, we identified that we needed to look at the capacity so that we could improve things going forward. And that does feed into our wider CQC improvement plan. So in terms of timescales for delivering the improvements on the back of the review, it will feed into that wider work that's going on.
And that will continue?
Yes, it will.
Okay, thank you very much.
Okay, thank you. Sue?
Thank you, Chair. Thank you, Kerry, and thank you, Francesca, for your report. On page 9, number 14, it says proportionate service review was undertaken. What are these posts that have been invested in that paragraph? Also, page 10, number 25. These posts referred to on page 9, number 14. What guarantee will the support workers be given that funding will continue under public health? And page 11, supporting carers, what guarantee will be given to lower the risk of carer breakdown and emergency interventions?
So just in relation to the posts and the staffing, so you'll see from the figures the demand in the service and how that peaked more than we would ever have predicted was clearly why we'd then carried out a service review to ensure that we'd got safe staffing numbers to support assessments, meet the outcomes of individuals, but also to make sure then that those existing staff didn't leave, that caseloads became unmanageable and we start to firefight risk. So that was why that particular service review at that point in time was done, to evidence the requirement for additional investment into the team, given the challenges with the current financial position. We'd got to provide clear evidence for that. Those posts are a combination of qualified social work posts and social care worker roles. So we had additional posts to meet that demand agreed based on the numbers and the trajectory for that service. That took a while for us to fill those posts, hence we had a pause on the service, which didn't mean that the work didn't get done, it just we had to draw upon the wider adult social care, social work services to start to support some of that so that we didn't have a backlog and people weren't waiting too long for assessments and care provision. So that was really important. The bit around the public health funding and the support work is, I can't give an answer on that yet. We're still waiting for some information to come to adult social care regarding public health funding and support work, because our understanding is that public health are still waiting for information regarding the use of the ring-fenced grant and our use of some of that grant in relation to some of the work that we undertake in adult social care to enable us to continue to fund support work. So meanwhile, we've got a small amount within base budget that allows us to continue to do some of that work, but we need to follow that up. Clearly, we can't have posts that we haven't got confirmed funding for.
Thank you both. My name badge has taken a dive off the table, so hopefully you don't forget who I am. Sue, is there anything else you wanted to add on that one? No? Okay. I've got Anthony next.
Thank you, Chair. And again, thank you for the report. My question is rather specific. Page 16, paragraph 59, interface with transitions from children's services. I'm asking this question not on behalf of a resident, but someone I know, and it's in regards to their son, who basically is autistic. He is on the spectrum, but he categorically refuses to interact with the system at all. And they have had struggles trying to get him to get help, to get support. Now he is now transitioning into the adult spectrum, into the adult sphere, on this. And I just wanted to ask, based on the fact that you say that you work alongside children's services to support earlier and better planned transitions into adulthood for autistic young people, will the county, with the social workers be approaching the child in that respect, where they are going from children to adults? And what support could I sort of put out there that there is available? Because it's not the fact that they don't feel there's any support. I think they basically struggle to try and find a direction because of the pressure they're under with the child. So really, I'd like to go back, if I could, and say, well, this is the best path to take in respect of now transitioning into the adult sphere.
Thank you. So one of the things that we do really well in Worcestershire is we track our young people. So we have operational meetings where we talk about young people from the age of 14 to look at their adult journey and to look at whether or not they're likely to need an assessment when they become 18. But also we like to talk about young people that are particularly hard to engage with as well, so we can plan who the best professional is to actually start to build a relationship and do the assessment. So what I'd probably suggest for that young person is that we maybe talk offline and we can have a conversation about how we can engage best with them and their family.
Okay, yeah, just come back on that. So at the age, I think he's 23, 22, 23, should that process have already started?
Yes, because what I guess I was talking about is a process where somebody's under 18 and they're becoming 18 and then becoming the responsibility of adult services if they've got Care Act eligible needs. So yeah, maybe if we have a conversation offline, we can make sure that person doesn't get lost.
Okay, that's great, thank you.
Yep, brilliant. Okay, thank you. So I've got Tor next.
Thank you, Chair. I've got a couple of questions about, the first one's about demand. It's specifically talking about paragraph 11, where you've seen a big grow in demand. In fact, I forgot to mention, thank you for this report. It's really useful, and I'm really glad we are doing lots of work for young people with autism. Obviously, any preventative work that we can do that helps them stay out of crisis and also helps them live independently is, I really support it. But in terms of demand, are we expecting to see demand grow even more over the next few years, and what measures do we have in place to deal with that, essentially? Then I've also got questions about paragraph 16 that talks about supporting independence of 15 autistic adults. Obviously you support more than 15 autistic adults. Is it that you've seen good outcomes specifically from those 15 adults? And who are now living independently, is my question. I don't know if that makes sense. And then my last one was about how we track this in a way, because we've got some really lovely case studies in there and I was really pleased to read all of them. And it says that we will get some quantitative data eventually. I know that preventative costs can be really difficult to track, and like I think you said earlier, it's difficult to know what money you don't spend, essentially. But in a similar way, are we able to track how much money we are saving from this programme? Yeah, thank you.
Thank you. I'll try and answer all of your questions in order. I'll do my best. So in terms of the first question about demand, so when I came to Scrutiny, it seems like a while ago, in 2023 in April, the paper that I produced had some really good information from public health about the rates of diagnosis and what that would look like for adult social care in the future. And we knew from that that the demand is going to increase and increase. And we know nationally that people are being diagnosed with autism and associated conditions much more now than before, and also later in adulthood as well. So we are going to see a huge demand. We can't escape that. And we're also very aware that we're working in quite a tight financial envelope as well. So a lot of what we're doing at the moment is looking at demand, looking at the demographic of people that we're supporting and the types of roles we've got in the team. So like I'd mentioned before, we've got a housing officer, we've got support workers, we've got social care workers, we've got social workers. So we're just at the moment in the process of working on, I guess, the next 5 years and what our staffing looks like and what our demand could look like as well. So there isn't probably a perfect answer I could give. I don't know if I could say we're definitely going to have enough staff over the next 5 years, but what we will do is work within the staffing we've got and support as many people safely as we can. Does that answer your first question? Okay, so the second question about the 15 people and the case studies, this was a snapshot of data, so I didn't want to capture everybody that had been supported in the service. We've had some really good outcomes on the whole for people. This is just a snapshot of people, so that's why it's 15. And then, sorry, just remind me what your third question was, just so I get it right.
My third question was about how we can track preventative costs.
Yes.
Yeah.
So I think Kerry had mentioned that there's some software that's been introduced, so we'll obviously tap into that and make sure we use that to track costs. But we have also been assessing the impact of the support workers aligned with public health outcomes as well. So we'll make sure that we track things that way to show like a cost sort of analysis. So. Okay, no problem.
Yep, Kerry, yep.
Just to quickly add as well, obviously this is a more specialist service in terms of a team, but the wider adult social care, social work services will also support people with neurodiverse needs alongside other needs. And obviously our SOPs do get updated to make sure that we've got the right people and the right sets of needs going to specialist services like the neurodiversity service, like our mental health service, learning disability service, etc. But then we've also got the wider social work services that will support people as well. So we do focus on what's our demand and staffing into this service, but along the way things can change in terms of those SOPs to make sure that we've got the right people in specialist services versus the right people in the wider service areas as well. So it doesn't mean that people don't have assessments and care and support plans when our demand spikes. We can draw upon support from other service areas where it's appropriate.
Thank you all. Michelle.
It's okay. I'll withdraw my question now. Thank you.
No worries. Thank you. Andrew.
Thank you, Chair. Yeah, thank you for another good and very encouraging report. I'm always hungry for quantitative evidence because obviously, as we're arguing about cost benefit, you know, everyone has to argue their corner. But obviously, the prevention is really clear from the case studies, and anything that will help us to sort of provide the bang per buck and avoiding further costs, cost prevention, etc., would be really welcome. So if it is possible within our constraints to provide a dedicated financial analysis of this A&T cohort, that would be really, really lovely, really useful. And paragraph 68, I really welcome the considered renaming to neurodivergent team or neurodivergent support service, you know, because autism is but one flavour of, etc. So really, really welcome that, and thank you. Keep up your good work and hungry for more data.
Okay. Sue, did you want to add anything?
Thank you, Chair. My question is page 17, number 65. It says as part of the next phase of development, service development, is this a new service or is it, how far have we come down the line and developed it? And also, what groups need the most engagement?
Thank you. So I guess in terms of the service, the autism service was established in around 2023. So we wouldn't be developing a new service, we'd be looking at changing the name. When we talk about the next phase, we are talking about more engagement with system partners. So we're in early conversations at the moment with mental health and housing about how we can offer a kind of joint preventative response to crisis situations for people, because as with the CQC assessment, we need to have a better response to when people are in crisis, like we'd said. So we are looking at that model going forward. So it won't be a separate team, but it will just be a bit more integration with the wider system. Did that answer your question?
Thank you. What groups need the most engagement? What age groups?
So we're going to work through that detail with our Autism Partnership Board, but I think missing from our board in terms of members is definitely younger people with neurodivergence. So we are in the process of engaging more with children's services to see who we can bring to be part of our conversations.
Thank you. I've got Richard next.
Thank you. Thank you, Francesca. And you know, I can see the great work that's going on. I don't have concerns so much with the transition from children's because we know them and we work closely with children's to take them on a journey and take them through from younger age to adults. My concern very much, and Torn raised the question, is with the older age demand. And it's not our issue, it's a national issue. As people become more aware of what the opportunities or the situations are for them to get tested and then supported. So I just Googled it actually, and it talks about current state of older adult diagnosis, exponential growth. Research shows a massive spike in adult autism diagnosis, with studies highlighting a significant rise, often over 150% in certain regions among those aged 35 and older. Then it talks about the lost generation. Up to 90% of autistic adults over 40 in the UK have gone undiagnosed for most of their lives, making this an area of increasing clinical focus. It is something that is happening, and we're going to have to be well aware of it. And I say it's a national issue, and we need to be lobbying nationally in terms of support for it. But where do we believe that sits locally, I guess, and how are we, you did talk about spreading it across adult social care, but how are we preparing for this? Because as we know, older people want answers in their lives, and if they believe that they've have something that may be on the spectrum, then they will get tested and then will need support.
I suppose I'll just challenge respectfully that they'll get diagnosed and they will need support. The majority won't. We're still going to be applying the Care Act eligibility criteria. And yes, you know, we absolutely have duties around prevention, and that's where, you know, a great adult front door, the upfront self-assessment, advice and information, what's on in your communities come into play for many of our residents. But the people that will come through to adult social care will be people who are likely to meet Care Act criteria. And certainly we would provide assessment and signpost for people. So we've seen a huge increase in diagnosis of people who are older, certainly whether that's through long waits that I understand through NHS provision for that, but quite significant increases in private provision, enabling people to receive a diagnosis, but it doesn't necessarily correlate with they are going to be people that will come through to adult social care, because actually many of those people will be very independent in employment, with housing, own tenancies, and able to manage generally their daily living needs. The people that will likely come through are those that aren't able to do that, and certainly there might be people of concern within communities that we would receive referrals through, or mental health services, but actually, you know, they need some support more around their neurodivergent needs, and they are more likely to come through, and we may then start to see an increase in numbers. And as I said earlier, some of those will automatically be supported through the wider social work teams with lower level needs, or directly through TAST or our adult front door, signposting, guidance and information, and those where they're more complex and having a significant impact on their well-being and the areas in the Care Act. Two or more of those, then those are the people that absolutely we would see growth in assessment and potential care provision for.
Okay, thank you very much. Anything to add on that one, Richard, or happy for us to move on?
No, I think that was a really helpful reply, because I think Kerry's quite right. It won't be everyone that needs support, so it's the appropriateness.
Yeah, brilliant. Thank you. Any members of the audience wish to ask any questions? Yeah, so you both put your hands right at the same time, so all right, okay, go on, Joe.
Thank you. Given everything we've discussed so far, and the financial pressures facing adult social care, is there any plans to replicate the preventative model in other areas where early intervention could reduce long-term costs?
So, Councillor Monks, I think in terms of, we've obviously heard earlier where the improvements are needed, that we're committed to making sure that we make those improvements. I'm not aware, other than what Kerry spoke about before, in terms of some of the work that we're doing around trying to understand, and Francesca alluded to it as well, in terms of trying to understand what impact we have by making a preventative offer earlier in people's journey with us. But other than obviously trying to do that, I'm not aware, unless my team tells me otherwise, that there's a specific area that we're focusing on in terms of prevention.
I think it will be helpful. I think it might be at the next scrutiny meeting, but don't quote me on that we're going to give you an update on the adult social care strategy and the prevention strategy. So a lot of the work around prevention will sit across adult social care, but quite specifically in the communities directorate. And there's lots of strands of work in terms of linkages with the voluntary and community sector, the work that we do in libraries around prevention, and many other strands of work. So that absolutely, you will get quite a lot of detail in terms of what we've achieved so far within the 5-year strategy. I think we're 3 years into that, hence we're going to be bringing an update. And prevention, as we've said earlier, we were strong within our CQC report, and lots of examples were shared with CQC of the work that we're doing before we're reaching adult social care's front door in terms of requiring assessment and services. So I think that will be really useful, and you'll have a lot more information on that when we bring that report in September, October, whenever that is.
Thank you, Chair. And Councillor Monks, I think I'm just reminded by a colleague, really, because sometimes we forget the significant investment that we make in our reablement service. So we invest in that service from the Better Care Fund, so arguably a joint funded service with our health colleagues. But they still work to a fairly high level of success in terms of particularly older people, admittedly, but we're still running around just under the 80%. So 80% of all people who go through our reablement service either have a lower level of need at the end of that input or have no input for adult social care at all. So arguably, that is very much a discrete piece of preventative work, although sometimes we don't put it under the badge of prevention. Yeah.
In addition to reablement in the way Mark's just described it, which is Pathway 1, the health and social care funded pathway out of hospital, we do have social care funded reablement services. So community reablement, which we have further invested in over the last few years. And in fact, it doesn't feel that long ago we didn't have that service at all, because that service had ceased due to financial pressures over the years. So we're really proud to have the community element back in. And one of the things that we'd been piloting over the last sort of 12, 18 months, I think it probably is, was a pilot we started in Wyre Forest, where we do a direct referral for people who are coming through our adult front door, and they go straight to community reablement. So we're bypassing social care assessment, sitting on a waiting list, for example, in a social work team, for a social worker to recognise that that person might need some short-term support to promote independence, some equipment, some consideration from one of the OTs, physios, or the reablement staff themselves. So we piloted that in the Wyre Forest. It was really, really successful. So we've rolled that across the county now, which again just speeds up the process and makes sure that, if there's been a significant change, but we think that's short term in someone's life, then we get that service in as quickly as possible to get them back to a level of independence, whether that requires some short-term support or some equipment or assistive technology. And for many of those people, they won't have an ongoing care and provision, but if they do, we know that that's much smaller and more cost effective than it would have been without that service.
Yeah, thank you both. That report that Kerry referred to, we have got it down for the 8th of October, so look forward to our next meeting, be able to scrutinise that. Anything else you want to add, Joe? Happy? Okay. Nick.
Thank you, Mr. Chairman. This report makes a compelling case that investing in prevention reduces demand, improves outcomes, and ultimately saves taxpayers money. I'm going to have another go at asking the Cabinet member a question. And the question is, what is your strategic vision for building on this work over the next 12 to 24 months? Specifically, what are your priorities for prevention in adult social care?
Chair, thank you. Prevention, I support prevention across the Directorate. It is very key, and without it, we all know that there is an ongoing cost, quite significant. But obviously, with the backdrop of last year's 9% council tax increase and the extra financial support we have, and due to only under £10 million worth of savings being made last year with the Reform Administration, this year it's going to make spend on prevention much more difficult because we have our savings are much higher now that we need to make. And this scrutiny isn't here to be a political meeting, so it's unfortunate the question I've been posed. But I support prevention across, and I will be working closely with public health as well, because that is one way we can measure outcomes. But it is across the Directorate, it's not one specific service. Thank you.
Thanks, Mel. Any further questions, Nick, or happy to move on?
The question, I'm afraid, wasn't political. It was, what was your plan? I think the response in itself made it political, referring to council tax increases and the statement made from reform. I think let's get past Thursday and let's see when the plan is produced. That's all I'll say at this stage. Thank you.
Okay. Any other panel members wish to comment on this item, or we can move on? Okay, brilliant. Well, thank you all very much. So if we move on then from the Adult Neurodiversity Team report onto so we've got item 7 is the performance and the 25-26 draft year-end budget monitoring. If it's okay with the panel, if we just sort of take those as a split at the moment. So if I first invite Katie to discuss the performance aspects, please.
Hello everyone. Okay, so you'll see from the report that our overall position at the moment is fairly mixed but quite a stable position. It's got strong performance from our reablement outcomes, but we've got ongoing pressures in demand and admissions and workforce capacity, which is having an impact. So you'll see for DAS 444, which is our admissions to permanent care for 18 to 64-year-old people, our latest position for March 2026 is 19.4 per 100,000, which is now rated as red, which is against a target of 13.4. This has improved slightly, although we're still over and we're above our target, it has actually improved. But our current position reflects that the ongoing system pressure following a spike that we had earlier in the year. Some of the drivers around this that we've got are things like there's delays in legal and contractual processes, panel decisions, timelines, continuing healthcare changes and funding disputes have had an impact on that, and then year-end purchasing activity also has an impact as to why that's slightly higher. But while the performance has stabilised in recent months, demand still remains high, and that's higher than historically our levels. So it's indicating to me a bit of a sustained pressure in the system, which is why that's still so high. Moving on to the admissions to permanent care for 65 plus, which is the DAS 306. Our latest position that you'll see for March is 643.1 per 100,000. This is rated green against our target of 645.9. However, there has been that gradual trend and increase, and you'll have seen that it's gone from 545 to now 643. But this is something that we're monitoring. I suppose it's just bearing in mind at this point that if it keeps increasing, we will at the next quarter be above our target. So we need to just keep monitoring that. Some of the pressures around this, around hospital discharges, activity, growth in our self-funder, to council-funded transitions, we've seen a high increase there, and continuing healthcare pickups has also had an impact on that figure. Outcomes of short-term services, our reablement, which is DAS 313. Our latest position for March is 85.97, which is green, and our target is 84. So again, we're looking really good in our reablement. This has always been a strong performance area for us, with outcomes improving and sustained throughout our winter pressures. More people are being supported through reablement whilst maintaining positive outcomes, which is what is really important. Our performance is above the national and comparator averages based on the latest benchmarking, but our data doesn't show that because of our client level data information that we've got. We've got some quality data issues, which I did make you aware of at the last meeting. We are working to improve that. And there's a new system coming in for our reablement team that we're hoping to get some better data out of, that we should be able to then update that a bit better so it actually shows the performance that we are doing locally, where it's not showing that at the moment. People at home following rehabilitation, DAS 314. Again, I can only apologise, we can't report on this one at the moment. The change in the methodology has meant that we can't access that data now. We've tried 3 different ways to try to gather that information, working with our ICB partners, and we just can't get the raw data to be able to bring that to you. So we've made a decision that we'll take this particular indicator off the list, and then when we do have the information, we will share it, which will be more of a yearly indicator rather than me telling you each month, I'm really sorry, we still haven't got it. There's been a slight delay in them producing the information this month. We should have had it by now and we haven't, so hopefully next quarter I will be able to update you on that one. But I suppose this gives a bit of an opportunity for you to inform us of something that, you know, if there's any particular data that you would like us to share with you in its place, you know, we can look to try and provide something that might be more tangible for you that you'd like to see. Then the annual care package reviews, DAS 413. Our latest position's 80.9%. Again, this is red. Our target's 95. We know that that's a high stretching target. But it's a target that we want to maintain and we want to continue to try to improve on. There has been improvement on that, so it has gone up. But again, the reason for the target is usually due to high demand. We've got reviews probably being deprioritised based on other higher risk work that's coming in. So it's not that it's not important, it absolutely is important, but because of that demand, that has an impact on that figure. Yeah, I think that's probably sums up the report really. So it is mixed, it is stable, nothing's massively changing, but there are some areas that I think we need to focus on a little bit more.
Thanks very much, Katie. Yeah, so if we move then to discussion about this report, so I've got Tor first.
Thank you for this report and thank you for your summary of it as well. It's really useful. My first question is just a very technical one. That on page 2 of the report, there is some commentary that just goes off the page, and it obviously at some point you could scroll down on that commentary, but when it's a PDF, you can't anymore. That's just something to highlight for future ones, but I'm sure it's something that can be resolved quite easily. I've got some concerns about admissions to care for 18 to 65. So we have a target of, I think it's 13 point something, is it 13.4? Since at least May 24, because you've got the graph below, we've been over this target and quite consistently. In fact, we've got a rising percentage, but the fact that we've been over that particular target for 2 years now doesn't look great. It's quite hard to tell from the graph below on the next page because there's no actual numbers on the side of it of when we were below that target or on target and when we were above. That would be nice in the future to have a bit of something on that graph so I could tell. But I guess my question is, what are the measures we put in place to try and keep people out of care actually working? Because we've been over the target for quite a while now. I've got some more, but I'll stop with that for
now. What this report, in terms of the current date, doesn't show is that actually when we looked at the most recent data in relation to both admission age groups, we were actually seeing a downward trend, thankfully, for, in that sense. We do whatever we can to keep people out of long-term care, clearly. And, we have, for example, a very good supported accommodation service that we offer to people that can make use of that. So not going into a larger institutional residential care for that age group. But what we do know, and again, it's sort of not just a Worcestershireism, we know that nationally the demand from the 18 to 64 age range, as we often refer to adults of working age in social care, is where there's significant increases in terms of demand and cost. So, you know, it's something that we'll have to continue to work on. We are engaged with a number of pieces of work in relation to what can we do differently as we move forward for that particular age group. But hopefully we are seeing some of that, some of those numbers start to come down from the current March position that's reported here.
And just based on your graphs, we can absolutely put some information in there from where it was actually on target to where it is now. So we'll add that in for the next one.
Just following up on that then, if that's okay. Where do we get this target of 13? Is it 13.4? I would be able to find it, but I can't. Where do we get that target? Because that would be interesting to know.
I think that's a target that we've actually set ourselves, if I'm honest. And this was before my time in joining the team, but it's definitely something that we've set that we want to try and achieve. So Kerry wants to go.
Yeah, I was just recalling this conversation quite recently, so email's great. You can do a quick scan, can't you? So this came up in March 26, and we had a conversation post-scrutiny with one of our lead commissioners around the target and whether actually we've got that target right, and clearly, you know, we haven't if we're constantly in the red or the actions we're undertaking are not effective. What she said was that when you look across nationally at that data, it sits around that level. But in Worcestershire, we really have got quite a significant ageing population, particularly of people with learning disabilities. And therefore, you know, we are Worcestershire. We're not, you know, we can't always compare ourselves with other areas. Though there was we're probably not there yet, but there was also an impact that we were likely to start to see decreases in as we were decommissioning 2 homes which would have residential care status. And again, you know, for an ageing population of people with learning disabilities and what alternatives that may look like, because obviously the registration of a provision is whether that's recorded as someone in residential care versus supported living, for example. So that was going to have a decrease in our numbers, and it would be interesting to see actually, seeing as we are starting to see a decrease month on month, whether that is in relation to that piece of work that she described in March 26. Also, the commissioners have done some piece of work around our age profile. It is surprisingly high from that piece of work. So again, the commissioner will feed some of that into future reports around that working age category here in Worcestershire. I think it is also important to note that there are some circumstances where it is best value for younger people to be in that setting, and that's not disregarding that we want good outcomes for people as well. We do, and we do make sure we do, but we also know that there are some circumstances where residential support is better value than supported living, for example, and that will therefore mean that our figures for some of those residential placements may be higher as a result of that.
Yeah, sorry, Toria, go for it. Yeah.
I'm glad that you mentioned comparing it to other counties and other districts, and I do understand that it can be really difficult. I mean, Worcestershire is entirely unique in a way, but it would be really good if we're talking about data that we could put into the report in the future, if there is anywhere that is similar to Worcestershire, that we can do some comparisons on and see how, you know, if there's something that they're doing that's better than us, that's more efficient than us, that would be really, really helpful for us to know, or whether they are exactly the same and they have the same percentage as people put into care as we do and they deal with it in the same way. That's would be really helpful for me.
Yeah, I'm happy to take that away and we can look into that, so it's fine.
Brilliant, thank you. Okay, I've got Dave next.
Thank you, Chair. Apologies to begin with if I've lost the plot and not followed you completely. Okay. And one of the things I can just say as an observation generally on figures and graphs and things of this nature that are needed is that we spend a lot of time, obviously as a scrutiny panel, looking backwards. But the trends we can see often are literally that, trends. I personally would like to see the commentaries giving more emphasis on what our plans are for the next quarter, the next period. I know Mark's spoken about the improvement plan, and I think Kerry has as well, being put forward, but I would really like to see that as a, if you like, a key piece of discussion work in the future at Scrutiny, at looking forward as well, of what can be done, because it's quite clear in some of these areas we are in a difficult spot, yeah, if not the country, and looking forward to that and just seeing what items we could put forward and show that we're doing. But to come on to the question anyway. Okay, so at page 31 is it? That's outcomes of short-term services, unless I've missed the plot here, I'm so sorry. We're down at 13%, aren't we, in March 25? Is that what we were previously discussing that, were we? Or it looks completely out of kilter with anything else?
That's where I was saying to you around our data, client level data.
Thank you.
It's not, nationally we're not reporting in the way that we should do because we've got some data issues.
As I said, I may have missed that point with my hearing aid, but there we go.
No, it's fine.
Okay.
So I know that would be highlight because you look at that and it looks a very alarming figure, but we are reporting on it locally, which is why we know we're performing really well. It's just being able to get our data to talk to the system that needs to talk to give them the
it's okay, you can
information.
stop
So
there.
it's
I did listen, but I thought I'd lost the plot there.
That's
Okay. Yeah. The one thing on page 29 as well, if I can just raise that, is we use the word AI again, being helped with annual care reviews. That's great. AI could be a really great tool for us. Just like to see a bit more grist on the mill there. All right? Thank you.
Okay, thank you. Yeah, if we can take that point away, then that is a really good point, though, all three of what you've raised. When I saw the 13%, I was quite a bit alarmed when I saw how low that was, so I'm grateful for you, Chachi, for raising that as well, so thank you. I've got Sue next.
Thank you, Chair. We know that prevention is now one of the key areas of adult social care, so Kerry, a report on this will be very helpful and useful for future comparisons. Right, the first page, the first chart shows a slight increase in the 3 months of this report. How are we going to ensure that these increases stay stable as the first 3 months' performance in other parts of the report are lower in some areas and higher in others? Thank you.
Thanks, Councillor Leacock. I think just in reference to the comment before by one of the members in relation to having a forward look on some of these reports, then I think we certainly already nodded to Katie in terms of trying to do that and look at, you know, the future direction of travel. And I suppose what I would say on that, this is obviously, we can only make judgments on what the data's telling you in front of us now. And this is March 26 data at this point in time. We're privy to actually probably a bit more information that's not in the public domain at the moment, but it does show some downward turn in relation to this first area, which is the 18 to 64 age group in terms of residential admissions. So hopefully some of what we are trying to do is beginning to have an effect, but certainly looking forward, it does look as though we're slightly down on the current numbers that are being reported, and obviously we'll get the opportunity to look at that at future scrutiny committees.
Andrew?
Thank you, Chair. Just on page 29, our slide talking about the annual care package reviews completed. This was one area where I sort of was, from our meeting papers, it indicates that our performance is poor against a local target of 95%, but the CQC stated that our review performance was above the England average, so it was at 80% and had been trending upwards over the past year, versus 60% England average. And I'm just wondering, why is our target set so high? Is it realistic? Is it a realistic aspiration? Is it an attainable target? Welcome your thoughts.
I'll pick this one up. I've been asked this many times over the years, and I'm always happy to explain why. An annual review is a statutory requirement within the Care Act. So setting a target that is lower than 95% is setting a target that's saying that we're going to be non-statutory compliant. 5% allows for people that are due a review, so we're at the 12-month point, but let's say they're in a crisis, they might be in hospital, there's a set of legitimate reasons why we can't review at that point in time. And that's where 95% comes from. The reality is, in most authority areas, it is much, much lower in terms of the percentages that are carried out, and we are really, really proud of that, nearly 81%. And in fact, I'm trying to think of the time, it was probably a decade ago that we got to the 95%. And clearly our financial position and demand on the service is very different now to what it was 10 years ago. It is an area of work that when we have critical business needs, so if we suddenly need to review everybody in a care home, and that could be 30 people, then we're going to transfer resource that is non-critical to manage critical work, and that will often be people that are due a review, that have services in place that we have no reason to have concerns about. That makes, absolutely makes sense, doesn't it? But what we are trying to do is look at ways of carrying out reviews as proportionately and as effectively as possible. And earlier on that, that was picked up around AI tools, but also around self-review. So a number of people want more control over the processes that we have in place. So we've built in and we're in testing stages of enabling people to actually write their own views and experience of their care provision and send that back to us, and then we will carry out that professional analysis and finalising and share a copy of their review with them. Now that won't be appropriate for many people, but for some it will. And therefore that will help us to improve. And when we do get our AI tools, such as, but not necessarily magic notes, then again, the recording of reviews will absolutely be able to speed up recording times and reduce practitioner time on administration tasks, and hopefully then get to carry out a few more reviews, and that will start to improve the figure. So long answer, apologies, but the reason it's there is because it's a statutory requirement. Assessments, actually, we have no statutory requirement in terms of timescales to carry them out. We have a local indicator. We like to carry them out within 28 days. And pre-Care Act legislation, it was 28 days. So we've stuck to that. But actually, reviews, we do have a statutory timescale attached to it.
Thank you. Yeah, Andrew. Yeah.
Yep. Thank you very much for that response. You have my every sympathy of coping within a sometimes complex national maze and hoops and requirements and targets that don't necessarily make sense or give a useful figure, and that can be distracting for members of a scrutiny panel like ourselves. But yeah, thank you for that explanation.
Okay. Joe and Nick, is there anything you want to add? No? Okay, brilliant. If we move on then, so we'll move on to the finance side of things. So for the draft year-end budget monitoring, so I've got Richard Stocks to cover the finance.
Fantastic, thanks Chair. So I'll be running you through the draft outturn position. I think just to reiterate to members, it's labelled draft because it hasn't yet gone through our external audit committee yet. So I don't envisage any of these numbers changing, but we couldn't put final because we haven't gone through the process. Okay. So we ended the year with a break-even position. However, we did have to use £15.5 million of reserves and £33.6 million of exceptional financial support. We saw overspends within adult social care and children's social care, so our demand-led services, and they're detailed on the table on your next page. Within the year, we did achieve our £12.5 million savings target. So they were fully delivered. If we hadn't, then the position would have got worse by that 12.5 million. On our high needs block, so I'm going through this in summary because I'm aware members have kind of seen this information before, so I don't want to waste your time. We did overspend the DSG by £82.6 million in 25-26, leaving the cumulative deficit of 180.8 million. We have submitted our SEND plan, which we're kind of waiting the outcome for that. If successful, we will achieve up to 90% of that 180 million. So significantly reduce that expenditure. The next slide in your packs, we put a new one in around debt. So the slide does say the debt stands at 40.4 million. However, some of that debt isn't 30 days old. Therefore, the total outstanding debt that is over 30 days is £28.6 million. And the majority of that does relate to social care, so adult social care debt. Within your slide pack, we have some information on our reserves. So we started the year with £93.7 million in our reserve balance, and we ended the year at 75.8 million. So we did use a significant chunk of the reserves there. But as always, some of these reserves are ring-fenced. We can only use the risk reserve line to offset expenditure that we see within the financial year. So that's our kind of non-ring-fenced reserve. So that stands at just over £22 million at the end of the financial year. Our capital programme for 25-26 stood at 681.4 million. So our capital programme does span multiple years. That's not all the money we're going to spend in one year. We did actually spend 122.9 million, so that's £27 million less than we thought that we would. We fund our programme in majority, over 60%, via external sources. The rest is funded either borrowing and capital receipts. So I will just remind members that when we do borrow cash to fund our capital programme, there are revenue implications of doing that. But looking at the overall programme, it's a much smaller amount than the grant value, which we don't have to pay kind of a borrowing cost for. And then in your slide packs, you have the capital programme and how it's split across the certain areas and how we funded it. And so I'm going to skip over those and move on to the adult social care specific area that we're going to be talking about now. So as I go through the table, which is in your packs, I'll kind of be talking through each area and what's driving the overspend. I'll then kind of give you a bit of narrative on why we've moved by about £5 million within the last quarter of the year. Okay. So in totality, the adult social care budget's overspent by £17.6 million. So it's a significant overspend that we've seen for the financial year. That is all within the client-led areas. So our older people, our learning disabilities, physical disabilities, and mental health areas. So if I touch on older people, which had an overspend of £5.6 million, £4.1 million of that related to residential and nursing care. What we've seen there is that the numbers of people coming into residential care are higher than we budgeted for, and we usually see a cyclical drop-off of clients. We haven't seen that this financial year, which you'll see kind of in the table in a later slide. So that's kind of pressure that's built all throughout the year, which equates to extra cost. We've also seen an increase in domiciliary care, so the number of hours that we're supplying for individuals has increased throughout the year. So that equates to a £1.8 million pressure. Although within domiciliary care, we're seeing the numbers of people within the service kind of reduce slightly. We're seeing the number of hours that people are having increase. Within learning disabilities, so this is the area of the budget we've seen the highest level of overspend of £10.2 million. The majority of that overspend relates to supported living. So the numbers of people that are coming through within supported living aren't far off our budgeted expectations. However, what we are seeing is the number of one-to-one hours that people are getting is above where we thought that we would. So that's driving quite a substantial change within that particular area. We have also seen within learning disabilities a fallout of continuing healthcare funding. So this is where we get funding from the NHS to support clients and residents within Worcestershire. that has reduced. However, we're still left with the cost. So effectively, social care is picking up some of that cost, when previously it was health funded. Residential services within learning disabilities overspent by £1.7 million. And what we're seeing there is the level of care required to look after individuals in our learning disability residential homes is above where we thought it would be. So that's an overspend. And daycare within learning disabilities grew by 12%, which equated to a £600,000 overspend. So again, we're seeing growth within our daycare area. Oops. Within physical disabilities, we overspent by just over £2 million, and that was residential and nursing services. So although the numbers of people that we're seeing coming in didn't increase as much as we did with the older people cohort, we're seeing the cost of supporting these people is costing us more. So the number of additional support that people are having is costing us more. And mental health and nursing services, supported living drove the majority of that £2 million overspend. So again, similar explanation to what's happening within the learning disabilities area. People are having more one-to-one hours of support rather than where we thought that we would. So there we have our client groups. Our commissioning unit underspent by £1.6 million. So what we were able to do in that area is get some additional income, one-off income that we thought that we would have. It's also a little bit of a presentational, I'm going to say issue, but a presentational point. The commissioning unit were allocated a budget for supporting with kind of fee disputes that we had with the market. So that area had over £900,000 budget, but we see the costs fall within the client groups above, so our learning disabilities, mental health, older people and physical disabilities. So just to say, that's kind of what's offsetting some of that. And the other point to mention is provider services underspent by £792,000. So our provider services is all of our internal support that we provide. We managed to achieve kind of one-off additional income there to offset that area. So in totality, that's our £17.6 million overspend. You will notice from the table we kind of moved from 12.4 to 17.6 million at outturn. What drove that? I'm not going to get into the complicated world of adult social care funding. However, we had an estimation that we were going to get money back from partners and other health organisations. So we've had funding disputes over 2 clients for multiple years, and they cost us £2 million. So we thought we were going to get the money back. After long conversations with our legal colleagues, it was deemed unlikely that we were. So being prudent, what we've done is say we're not going to get that cash back. We are still working to get that money back. So if we do, that's going to benefit us in 26, 27, I forgot what year I'm in, sorry, talking different financial years. So that was £2 million of that £5 million movement. We also saw quite an increase, as I've mentioned, the drivers, so dom care and supported living one-to-one hours that we've put in, those equated, bear with me, I've just got to check my notes, to £2.9 million. So effectively, that £5 million is split between the increase in one-to-one hours and the debt, or the amount of money we're not going to get back. So the point I would like to make on our, I guess, position, we overspent by 17.6 million. However, in our care market, we actually spent £21.4 million more than the budget. So what we were able to do as a directorate is offset some of that £21 million by one-off income, underspends within staffing, etc., to net that down. But we do have a cost pressure within the market. Within your slides, you'll kind of see some extra narrative on kind of just some highlight areas that we've kind of picked out. I've tried to kind of give you a bit of narration alongside the table to help you understand what's driving that overspend. I referenced the graph, which is labelled trend in placement numbers. So if we look at the tail end, our 25, 26 reference points, we'll see that they kind of go up and then they remain fairly stable. Within prior years, we've always seen a little bit of a drop-off. So this year is a little bit different from a trend perspective, which drives a cost implication of things not happening that we think we would happen based on previous data. And we've also got our trend line of where we may end up by the end of the financial year for 26-27. So it's around the 7,600 packages compared to around the 7,300 that we're at now. So around a 300 package increase, which we had about 211, I think, increase last year. And my last slide to talk through is our unit cost slide. So I'm aware if you've got it printed out, it's going to be in grayscale, so it's not actually going to help you know which line is which. However, the line at the top is our younger adults, so that's our average cost for supporting our younger adult cohort only. The next line down is all of our clients, so that includes our younger adults and our older adults, and the bottom line is our older people line. So we're kind of just showing you where we are with regards to costs, and we can kind of see those increasing as we go throughout the financial years. So I'm kind of happy to take any questions.
That's brilliant. Thank you very much, Richard. Yeah, so if I just remind members with regards to questions, if we can just obviously keep it within the remit of adults care rather than sort of more wider budgetary things. But if I go to, I've got Dave first, and I'll make my way around. So, Dave.
Thank you, Chair. Yeah, in the spirit of trying to keep it within the scrutiny panel here, I mean, the word scrutiny is to look at what's occurred and then to scrutinise, but I find it very difficult really in one way because we're moving forward and we can see trends, we can see the increased demand that you guys and girls are having to really deal with, and it's frightening from my position, looking at the challenges that you've got. And we've talked about an improvement plan, and I'll bring that into the matter in a moment. We talked about an improvement plan being discussed, and given all the ramifications, financial pressures on this county at the moment, I think it would be great if we could just look a little more forward in terms of planning. And I know that the cabinet member here today mentioned about politics, but whoever is in power, whoever it is, I would be saying this, is that we should be looking at the plan to take us forward. And I would welcome, not just at this scrutiny panel for this, but any scrutiny panel, looking at the steps and plan in detail. Because in the report that we've got in front of us here, it talks about mitigation, but it gives no idea about what. And thank you for obviously what you've discussed there and moving about how you've actually moved figures about. Yeah, but I would really like and welcome a view at this point in the future of how we're moving forward and what the plan would be, so that when we come back and sit here in October, we would have more, we would be invested to put more in there. I hope that makes it clear from my point of view, but that's something that I've felt over the last number of months now. We're looking at this. They're always looking backwards to a degree, and I don't not see, bad grammar, not see that we aren't putting commentary behind things about how we're moving forward, but I think there could be a lot more emphasis put on the forward position. And I'll leave it there. That's some of the questions would have been, for instance, where are we getting this money from in directors' mitigation? In some of the directors continue to work on mitigation strategies to reduce the impact of increasing costs. How? How is what I would ask. And if that a little bit more information was given there, I think that would be welcomed by everyone. Thank you very much.
No, thank you, Dave. It is a really good point. You know, obviously we can scrutinise the figures of what's happened in the past, but we also need to look forward to ensure that we are doing those mitigations for the future. So definitely something we can take away. I appreciate, obviously, with regards to some of the figures, we'll be bound by what's happened in the past, but there definitely does need to be some more forward thinking as well. So happy to take that away. Mark, did you want to come in?
Thank you, Chair. Councillor Edmonds, we're actively, as you would expect, working through plans now, looking forward to 26, 27 in terms of what are the mitigating actions to avoid some of those costs going forwards or make some savings from the service. I'll give you probably one example, because I think it's probably more in the public domain at the moment, where some of the other plans aren't in that sort of public domain. But there's been a recent Supreme Court judgment in relation to deprivation of liberty safeguards. We are planning and working through what that means going forwards, but we will have the opportunity to deliver a very different service into the future, which we expect will cost us less than that current work does. So it's those sorts of things that we're anticipating, we're looking at. Not all of our draft proposals are in the public domain at the moment, but we absolutely are working on that forward look in terms of what we do about the pressure on the budget. And just to say as well, though, on a daily basis, or a weekly basis at least in a sense, certainly Kerry sat to my left is involved in panel meetings where each case for people aged 18 to 64 comes across a panel of people that scrutinise the spend on those particular packages. So we do that on an ongoing basis as much as we are also considering what other plans we might have. One final thing I will say, and the volatility and risk that is sat within adult social care budget is immense. And one of the reasons I say that is that some of the impacts that we see on adult social care budget is not within our own gift. And one firm example I'll give of that is where people, as already been alluded to by Richard, are currently in receipt of continuing healthcare, who are then reviewed with our involvement by the health service, and a decision's made that they are no longer eligible for continuing healthcare. And what that consequently happens, the care that people are receiving comes back to adult social care. There is also then a cost to the individual, which there isn't under continuing healthcare. And these are not insignificant numbers at the moment. It talks potentially to Councillor Pingree's comment around 18 to 64 residential places going up. Well, if you're in a residential placement under continuing healthcare and you come off continuing healthcare, then that's another factor for social care to think about in terms of numbers, but also cost. So the real issue is just the volatility of the environment we work in.
Thank you for that reply, and by no stretch of the imagination do I feel you're sitting in a very easy seat, any of you. And I totally get the volatility of the situation there, but we can only plan with what we know. And all I'm saying really is, looking backwards all the time, we should be looking forwards with what we've got, and that would help. And it's very difficult. It's obvious to anyone that's listening to this or in the room today that it isn't a difficult situation, but we can only put our best foot forward with this. And all I'm asking for is that we look forward a bit more in a lot of the areas here. With the pressures that are on the county, obviously, we're clinging on. We've got a massive deficit. And talking about that, the one thing I would like to just raise there, because you have touched on that to a degree, is there is a volatility. At the moment, we've got a claim in, haven't we not, for the send expenses, is that correct? 80%, we're due to get back 80 to 90%. Is it DFG? Yeah, the deficit there. Now, the plan's been put in to be approved, and we're all sitting here. Well, what if that wasn't to happen? What if that wasn't happening? That would be a volatile situation, not to say the least. Without that happening, we really are in a dark place. So I think what I'm saying is we need to have everything on the table in terms of how we're moving forward in terms of the plan. Okay, thank you very much.
Thank you. No, thank you. It's a very well made point. Kerry, if you want to come in on that, yeah?
Yeah, I just thought it might be a good example to follow on from Mark's response regarding continuing healthcare. So thinking ahead, what we have done is reinstated through a business case to invest to save, to test the model of having a continuing healthcare specialist social work team. It's very small. We did bring a paper on continuing healthcare, which will still be available. And what that is doing is saying, you know, if it costs X amount for 5 social workers, for example, but that means that we can attend and ensure that people's continuing healthcare continues where we believe they're eligible for it to continue, that we can attend disputes and have the evidence that we need to carry out those disputes, that people that have been fast-tracked, so they're at end-of-life, rapidly deteriorating stages, but then they're no longer fast-track, that we make sure that they continue to be, if we believe they should be, and certainly if they come through to social care, we make sure that we have those really detailed conversations with people around what the offer might look like from the council that could be quite different from the offer from the health service. So we did an invest to save piece of work, I think about 12 months ago, and what we've found now is that that's paid for itself in that sense, in terms of what it costs to have those staff versus making sure that we've avoided costs wherever possible. What we're doing now, thinking ahead, is utilising some of that resource to look at those very high cost care packages and start to trigger new continuing healthcare checklists to take them through that process again if we think some people have either become not eligible or we think they have grounds for eligibility from the information we could see. So that's very much a forward-thinking piece of work that said we need investment despite the financial challenge for a small amount of additional staff. This is what we'll focus their work on. We think it will pay for itself. We've tested it, but now we've got to reduce those recurring ongoing costs, not just look at avoidance, and hence we're carrying out those top 20 high cost cases and starting to see, what we can do with those.
I'd just like to say thank you for your efforts. By no stretch of the imagination, as I said before, do I not realise the seat that you are sitting in today. And we are merely councillors here looking at figures in just black and white, really. You're living this life in that position. So thank you very much.
Andrew?
Thank you, Chair. And thank you all. I mean, you're working under a lot of pressure and with really, really important topics. So every aspect of this care provision and or commissioning really makes or breaks quality of life for residents. Well, on achieving the £12.5 million savings over the year, and this 17.6 that we're looking at, the shortfall for this year. Just wondering what sort of shortfall could or should we be anticipating for the next financial period? I mean, what sort of ballpark figure? I know it's really hard to, as the investors say, past performance is no indication of future. But if you had to help people who are putting a budget together, what sort of figure are we realistically needing to find?
There has been a figure internally communicated. I don't think that yet has been communicated to the public, so I won't be answering that point. However, when we look at the investment that we've seen within social care for 26-27, we did put just shy of £25 million into the budget, because we have this recurrent pressure from 25-26 that we've seen, plus we are going to have growth in the numbers of individuals that we're going to support, plus there's going to be growth in price. So if I can just reiterate to members, we have put just shy of £25 million into the social care budget. And there are some pockets of pressure that we're seeing currently.
Happy to talk offline with whatever isn't yet ripe for public domain.
Thank you. I've got Tor next.
Thank you, Chair. I just want to talk a little bit about the trend in the average unit cost, which I assume is our average unit cost, not across the whole of the UK. And it's more of a moan than anything else, than a question. But I would really like to see on there how we compare, again, comparing to the UK unit costs and things like that, because I know that we've spoken before that we've got a really good supply of care packages,
and care providers. We're really able to negotiate on those packages. I know we've spoken about especially our healthcare for over 65s. We've got really good value on that, but we are still unable to meet the costs of our adult social care. And it almost feels like it's not, if we put that data in there, it really hammers home that we are doing everything that we can to try and bring costs down, but we aren't provided with enough money essentially to make it work, and that would be really useful for me to be able to show my residents that, look, we're really trying here, but it's just the numbers aren't coming together.
Just a quick comment, Councillor Pingree, on that. If you look at the last slide in Richard's slide deck, which looks at that unit costs, and I've quoted this before many times, if you look at older people, the unit costs is right down there. And what I know from, although it's slightly dated, so it won't meet Councillor Edmonds' requirements in terms of forward-looking, because some of the work that the Local Government Association and ADAS do, for older people, it points to the fact that for a package of care for an older person, compared to England average, we spend £300 less than the England average on older people. So that's certainly that. I think the one that then sticks out, doesn't it, is the younger adults is the one that's up there, and it's all that conversation that we've had at Scrutiny today, which just is the complex issues that we face in that drives those costs up. So that would be sort of a general comment I would make. But your point in terms of whether we can bring some comparison data into this conversation is a well-made one, and we can always look at that. I know Richard's puts his hand up to comment.
Yeah, if I can. Just to say, one of my actions from a previous scrutiny panel was to look at unit costs for provisions of care with kind of local partners. So I am part of the West Midlands Finance Group. The question has been asked to share the data. It is being compiled. From what I don't have the data yet. When I do have it, if I can share it, I will. What we're looking at is kind of a snapshot in May 25-26 and a snapshot in May 26-27. Therefore, we can identify kind of what costs are looking like and increases, and are we seeing pressures across the areas. So if I can share that. Rebecca's got a finger up, so I'll pass the mic.
And when we do that, please can you accept that it will come with a very large health warning, in that these will be looking at costs. It will not necessarily be looking at exactly the same service, because the specification for the service and the entry points to them could be very, very different. Also, there will be a number of quite significant demographic changes across the 14 authorities of the West Midlands. So the answer is yes, it can be done, but please, you will need to accept that it comes with quite a large health warning, and actually gaining some of that data, even if we go for demographically similar counties in terms of, for example, a mix of rural and urban or semi-urban areas. Again, they may not have the same specification of service that we do. So it is very difficult to draw an exact comparison, but a comparison can be bought, but with a warning.
Okay, thanks all. Joe, I've got you next.
Thank you, Chair. A couple of points and questions. This is for the Cabinet member. So the Council continues to rely on EFS and reserves to balance its budget. What specific actions are being taken within adult services to reduce reliance on government support over the next 2 financial years? And also, the CQC has recognised Worcestershire adult social care as good service with strong leadership, safeguarding and prevention. At the same time, the Council faces the continuing financial pressures, as I've just mentioned. So how will the Cabinet member ensure that the financial decisions made over the next 12 months protect the quality of services that the inspectors have praised, while still delivering the savings the Council is going to require? Thank you.
Chair, thank you. Yeah, there is work going on. There is a significant amount of work going on which is not yet in the public domain. As soon as it is, it will be released. But please rest assured that work is continuing. And with regard, I guess the other one is maintaining quality. This particular department, this directorate has made significant savings before and in the past for the council on many occasions, and I have every confidence that we can do that again. And as a current cabinet, we have committed to the 4.99% council tax. We're not looking to go above that. So I think with transformation, creativity and a lot of hard work, I do feel comfortable it will be achieved. And as soon as I can release things, obviously we will, so you can see the detail. Thank you.
Yeah, sure, Joe, yeah.
Okay, I don't think it was related to council tax question, and you know, I mean, that shouldn't have been mentioned. What I'm trying to get at is, are we going to rely on LGR and the process going forward with that? Can you comment on that one for me, please?
Yes, absolutely, and apologies. Yeah, obviously with LGR, we should know Thursday, but obviously if we stay as one council, one Worcestershire, this service will remain as a service in a whole, and I think that will make the work streams much easier. If we do become a north and a south for ourselves and for our colleagues in children's services, and also to a lesser financial extent, but also in highways, there will be significant work that will need to go on behind the scenes, but we do need to see how that's going to look on Thursday. Thank you.
Yep.
Yeah, sorry, I think I'm specifically looking at, are we going to be reliant on LGR to fund ourselves to keep us out of a 114 again? Thank you.
Sorry, if I just jump in case I've lost it. Is it LGR we're looking for? Is it EFS we're also considering as your thing you're relying on? Is it both? Is it both? Okay.
I'm not sure I'm entirely possibly understanding the question. Obviously, LGR will happen, so we're not reliant on that. That is a process that will happen. And as regards with EFS, again, all the financial decisions that have been taken for adult are not yet in the public domain, and I think you would need to comment corporately with EFS as the council as a whole. That would be more of a question for the leader at council. I wouldn't like to comment. I'm not on that one here. Thank you.
No, thanks all. I think we're happy to...
I'll take it forward to council. Thank you.
Yeah, okay. Nick?
Thank you, Mr. Chairman. I think my questions are around... The main thing is we know what the constant here is. We know what our funding settlement is for the next 3 years. So we know we've got a sum of money coming from the government. But from my perspective, when you look at the finances, increasing complexity, inflationary pressures, the money we receive from government is nowhere near enough. So the one thing I just want to gain an understanding from the officers and the cabinet members, what lobbying activity is taking place at the moment to actually question the settlement package that we've got, 'cause it's clearly not enough in this area. Thank you.
Chair, if I may, in summary, obviously we do know the 3-year funding settlement, and corporately the amount the funding increases by, I absolutely agree with Councillor Price, it's nowhere near enough money. So that does place us with significant challenges which we will tackle. But there is lobbying that is going on, that has been going on, but from a personal point of view, it feels very much as though it's falling on deaf ears. But I will pass over to Mark to give you more detail. Thank you.
Thanks, Councillor Price. Yeah, I mean, we're continually involved in lobbying through whichever mechanism we can draw on, really. So I'm and others on the team are actively involved in West Midlands ADAS. We do take through those meetings to ensure that national ADAS know what is on the agenda and what we're lobbying for. There'll obviously be more informal conversations I'm aware of with MHCLG that take place probably with the Director of Finance from that point of view. So I guess the answer from my perspective is we do whatever we can to lobby in relation to changes that we would like to see. However, fundamentally, as long as the Care Act is in place in its current form, then there's very little wriggle room in terms of, how we might do things somewhat differently to avoid some of the costs that we have. I mean, the only other thing is the example I gave earlier around deprivation of liberty safeguards. I think that was really welcome. that we got that judgment through the Supreme Court and the challenge that came from the Northern Ireland Minister. And we'll work, as I say now, to look at how we take that service forward. And I genuinely expect that we will reduce costs in that particular part of the service, and that will bring a saving into the future.
I think just as well, for another example, we are aware, of course, that the government has consulted upon issues such as fair pay agreements, which it intends to introduce and be active from April 2028 for adult social care. We also know that this is not going to be funded, and we have no idea how it's going to work or what it's going to look like. But in terms of our response to that, of course, as a county council, and indeed many of the other organisations such as ADAS, the finance networks and so on, have all contributed to that consultation. But whatever happens, we will be duty bound by whatever comes out from it, but we may have no influence or indeed the funding gap, if there is one, to be covered. So we have a lot of issues looking ahead that actually, your guess is almost as good as ours in terms of where that will lead us. But we have to wait and see. We anticipate, I think, on that one, that we should have some clearer indication by the end of the year, but we have no date that is set.
Thank you all. Nick, is something you want to come back on?
Just one more supplementary, thank you. We're talking about the fair pay section. Do we sort of know what the tangible impact would be in monetary terms to the council?
No, because we don't know how it's going to work yet, and we don't know what it's going to look like, but there will be a national negotiating body that is going to set a fair rate of pay. The consultation was even unclear in terms of what that would mean or which groups of staff it would cover. There were a lot of comments that went back because pending the groups that it covers could lead to extraordinary numbers of equal pay claims across the entire sector. We know what happened in those in a certain authority not a billion miles away. But also even elements that had not been considered prior to the consultation, and actually, unless you were smart and you wound your answers in as part of the consultation, it wasn't covered either. Let's not forget that there are large numbers of people, and in this county particularly large numbers of people who actually pay for their own care, they self-fund it. However, if the cost of care goes up significantly, the rundown on their own financial position will also increase, which will then bring greater numbers of people, or a faster rate of people, coming under local authority care. And so the implications are huge. I don't know how we're going to minute it, but frankly, I think none of us have a clue.
Thank you.
Thanks all. Anybody else wish to raise anything on this? Okay, brilliant. That takes us on then to the work programme. So that's the last item on our agenda. Anything members wish to add? Michelle?
Thank you, Chair. Yes, the minutes from the January meeting recorded that agreement was made to add assurance that commissioning processes were effective, but I think really it's not just the commissioning of services, but the assurance that the monitoring of the delivery of commissioned services is meeting expectations. If we could add that to the agenda, it's not been added as yet, although that was January.
Yeah, no, that's a really good point. Happy for us to take that forward. Anybody wish to comment on that, or they got a separate proposal? Okay, Andrew?
Separate thing, please. If we could include a 6-month review of our CQC improvement plan delivery.
Yeah, a 6-month review. Yeah. I haven't got any shakings of head from members, so I think we're happy to consider that one and take that forward. Anything else? No, okay. It's just a bit from me. I know I did mention to members earlier, but obviously with LGR, we're expecting the decision imminently, so just something worth keeping our eye on. So maybe something we have to bring to this committee quite soon, but let's keep an eye on what happens there. So, yeah, Andrew.
Sorry, one other thing to add. If we could keep an eye on the sort of the value for money review of the adult neurodiversity team after that pilot has concluded, please.
Yes, happily, yes. Yep. Okay then, brilliant. Well, thank you all very much for coming today and taking part. I think we've got some good recommendations and things to take forwards as well. So thank you all, and I'll bring that to a close.